Chapter 4. Delirium. Delirium is an acute mental status change characterized by abnormal and fluctuating attention. There is a disturbance in level of awareness and reduced ability to direct, focus, sustain, and shift attention. American Psychiatric Association, APA, 2013. These difficulties additionally impair other areas of cognition. The syndrome of delirium can be a physiological consequence of a medical condition or stem from a primary neurological cause. Delirium is by far the most common behavioral disorder in a medical surgical setting. Most physicians across medical and surgical specialties are faced with delirious patients at some point in their careers. In general hospitals, the prevalence of delirium ranges from 15% to 24% on admission. The incidence ranges between 6% and 56% of hospitalized patients, 11%-51% postoperatively in elderly patients, and 80% or more of intensive care unit (ICU) patients. Alsay et al. 2013. Inoue et al. 2014. The consequences of delirium are serious. They include prolonged hospitalizations, increased mortality, high rates of discharges to other institutions, severe impact on caregivers and spouses, and approximately $150 billion annually in direct healthcare costs in the United States. Kerr et al. 2013. Leslie and Inoue, 2011. The 30-day cumulative cost of ICU delirium per patient is more than $17,000 and would be even higher if not for the high mortality associated with ICU care. Vasilevskis et al. 2018. Knowledge of delirium dates to antiquity. Hippocrates referred to it as phrenitis, the origin of our word frenzy. In the 1st century AD, Celsus introduced the term delirium, from the Latin for out of furrow, meaning derailment of the mind, and Galen observed that delirium was often due to physical diseases that affected the mind, sympathetically. In the 19th century, Gowers recognized that these patients could be either lethargic or hyperactive. Bonhoeffer, in his classification of organic behavioral disorders, established that delirium is associated with clouding of consciousness. Finally, Engel and Romano, 1959, described alpha slowing with delta and theta intrusions on electroencephalograms, EEGs, and correlated these changes with clinical severity. They noted that treating the medical cause resulted in reversal of both the clinical and EEG changes of delirium. In sharp contrast with this long history, physicians, nurses, and other clinicians often fail to diagnose delirium. Wong et al. 2010. And up to 2/3 of delirium cases go undetected or misdiagnosed. O'Hanlon et al. 2014. Healthcare providers miss this syndrome more from lack of recognition than from misdiagnosis. The elderly in particular may have a quieter, more subtle presentation of delirium that may evade detection. Adding to the confusion about delirium are the many terms used to describe this disorder. Acute confusional state, altered mental status, acute organic syndrome, acute brain failure, acute brain syndrome, acute cerebral insufficiency, exogenous psychosis, metabolic encephalopathy, organic psychosis, ICU psychosis, toxic encephalopathy, toxic psychosis, and others. One of the most important clinical distinctions is that between delirium and dementia, the other common disorder impairing multiple cognitive domains. Delirium is acute in onset, usually hours to a few days, whereas dementia is chronic, usually insidious in onset and progressive. The definition of delirium must emphasize an acute behavioral decompensation with fluctuating attention, regardless of etiology or the presence of baseline cognitive deficits or pre-existing dementia. Complicating this distinction is the fact that underlying dementia is a major risk factor for delirium. Clinicians must also take care to define the terms used with delirium. Attention is the ability to focus on specific stimuli to the exclusion of others. Awareness is the ability to perceive or be conscious of events or experiences. Arousal, a basic prerequisite for attention, indicates responsiveness or excitability into action. Coma, stupor, wakefulness, and alertness are states of arousal. Consciousness, a product of arousal, means clarity of awareness of the environment. Confusion is the inability for clear and coherent thought and speech. Clinical characteristics. The essential elements of delirium are summarized in boxes 4.1 and 4.2. Proposed criteria for this disorder are a neurocognitive disturbance that develops over a short period of time, tends to fluctuate, and impairs awareness, attention, and other areas of cognition. APA, 2013. In general, awareness, attention, and cognition fluctuate over the course of a day. Furthermore, delirious patients have disorganized thinking and an altered level of consciousness, perceptual disturbances, disturbance of the sleep-wake cycle, increased or decreased psychomotor activity, disorientation, and memory impairment. Other cognitive, behavioral, and emotional disturbances may also occur as part of the spectrum of delirium. Delirium can be summarized into the 10 clinical characteristics that follow. Acute onset with fluctuating course. Delirium develops rapidly over hours or days but rarely over more than a week, and fluctuations in the course occur throughout the day. There are lucid intervals interspersed with the daily fluctuations. Gross swings in attention and awareness, arousal, or both occur unpredictably and irregularly and become worse at night. Because of potential lucid intervals, medical personnel may be misled by patients who exhibit improved attention and awareness unless these patients are evaluated over time. Cognitive and related abnormalities. Attentional deficits. A disturbance of attention and consequent altered awareness is the cardinal symptom of delirium. Patients are distractible, and stimuli may gain attention indiscriminately, trivial ones often getting more attention than important ones. All components of attention are disturbed, including selectivity, sustainability, processing capacity, ease of mobilization, monitoring of the environment, and the ability to shift attention when necessary. Although many of the same illnesses result in a spectrum of disturbances from mild inattention to coma, delirium is not the same as a primary disorder of arousal. Confusion or disorganized thinking. Delirious patients are unable to maintain the stream of thought with accustomed clarity, coherence, and speed. There are multiple intrusions of competing thoughts and sensations, and patients are unable to order symbols, carry out sequenced activity, and organize goal-directed behavior. The patient's speech reflects this jumbled thinking. Speech shifts from subject to subject and is rambling, tangential, and circumlocutory, with hesitations, repetitions, and perseverations. Decreased relevance of the speech content and decreased reading comprehension are characteristic of delirium. Confused speech is further characterized by an abnormal rate, frequent dysarthria, and nonaphasic misnaming, particularly of words related to stress or illness, such as those referable to hospitalization. Altered level of consciousness. Consciousness, or clarity of awareness, may be disturbed. Most patients have lethargy and decreased arousal. Others, such as those with delirium tremens, are hyperalert and easily aroused. In hyperalert patients, the extreme arousal does not preclude attentional deficits because patients are indiscriminate in their alertness, are easily distracted by irrelevant stimuli, and cannot sustain attention. The two extremes of consciousness may overlap or alternate in the same patient or may occur from the same causative factor. Perceptual disturbances. The most common perceptual disturbance is decreased perceptions per unit of time. Patients miss things that are going on around them. Patients may experience visual distortions, such as illusions, misperceptions, and even pareidolias, or the recognition of familiar objects or patterns superimposed on random stimuli. These perceptual abnormalities may be multiple, changing, or abnormal in size or location. Hallucinations are particularly common among younger patients with the hyperactive subtype. They usually occur in the visual sphere and are often vivid, three-dimensional, and in full color. Patients may see Lilliputian animals or people that appear to move about. Hallucinations are generally unpleasant, and some patients attempt to fight them or run away with fear. Some hallucinatory experiences may reflect intrusions of dreams or visual imagery into wakefulness. Psychotic auditory hallucinations with voices commenting on the patient's behavior are unusual. Disturbed sleep-wake cycle. Disruption of the day-night cycle causes excessive daytime drowsiness and reversal of the normal diurnal rhythm. Sundowning, with restlessness and confusion during the night, is common, and, in some patients, delirium may be manifest only at night. Nocturnal peregrinations can result in a serious problem when the delirious patient, partially clothed in a hospital gown, has to be retrieved from the hospital lobby or from the street in the middle of the night. This is one of the least specific symptoms and also occurs in dementia, depression, and other behavioral conditions. However, in delirium, disruption of circadian sleep cycles may result in rapid eye movement, REM, or dream state overflow into waking. Altered psychomotor activity. There are 3 subtypes of delirium, based on changes in psychomotor activity. The hypoactive subtype is characterized by psychomotor retardation. These are the patients with lethargy and decreased arousal. The hyperactive subtype is usually hyperalert and agitated and has prominent overactivity of the autonomic nervous system. Moreover, the hyperactive type is more likely to have delusions and perceptual disorders such as hallucinations. Approximately half of patients with delirium manifest elements of both subtypes, called mixed subtype, alternating between hyperactive and hypoactive. Only approximately 15% are strictly hyperactive. In addition to the patients being younger, the hyperactive subtype has more drug-related causes, a shorter hospital stay, and a better prognosis. Many patients who present with an initial hyperactive phase evolve to a predominant hypoactive delirium. Disorientation and memory impairment. Disturbances in orientation and memory are related. Patients are disoriented first to time of day, followed by other aspects of time, and then to place. They may perceive abnormal juxtapositions of events or places. Disorientation to person, in the sense of loss of personal identity, is rare. Disorientation is one of the most common findings in delirium but is not specific for delirium. It occurs in dementia and amnesia as well. Among patients with delirium, recent memory is disrupted in large part by the decreased registration caused by attentional problems. In delirium, reduplicative paramnesia, a specific memory-related disorder, results from decreased integration of recent observations with past memories. Persons or places are replaced in this condition. In general, delirious patients tend to mistake the unfamiliar for the familiar. For example, they tend to relocate the hospital closer to their homes. In a form of reduplicative paramnesia known as Cagras syndrome, a familiar person is mistakenly thought to be an unfamiliar imposter. Other cognitive deficits. Disturbances occur in visual spatial abilities and in writing. Higher visual processing deficits include difficulties in visual object recognition, environmental orientation, and organization of drawings and other constructions. Writing is easily disrupted in these disorders, possibly because it depends on multiple components. The most salient characteristics are abnormalities in the mechanics of writing. The formation of letters and words is indistinct, and words and sentences sprawl in different directions. Fig. 4.1. There is a reluctance to write, and there are motor impairments, e.g., tremors, micrographia, and spatial disorders, e.g., misalignment, leaving insufficient space for the writing sample. Sometimes the writing shows perseverations of loops in aspects of the writing. Spelling and syntax are also disturbed, with spelling errors particularly involving consonants, small grammatical words, prepositions and conjunctions, and the last letters of words. Behavioral and emotional abnormalities. Behavioral changes include poorly systematized delusions, often with persecutory and other paranoid ideation, and personality alterations. Delusions, like hallucinations, are generally fleeting, changing, and readily affected by sensory input. These delusions are most often persecutory. Some patients exhibit facetious humor and playful behavior, lack of concern about their illness, poor insight, impaired judgment, and confabulation. There can be marked emotional lability. Patients can be agitated and fearful or depressed and apathetic. Dysphoric, unpleasant, emotional states are the more common. Up to half of elderly delirious patients display symptoms of depression with low mood, loss of interests, fatigue, decreased appetite and sleep, and other feelings related to depression. There may be mood-congruent delusions and hallucinations. The mood changes of delirium are probably due to direct effects of the confusional state on the limbic system and its regulation of emotions. Finally, more elementary behavioral changes may be the principal symptoms of delirium. This is the case especially in the elderly, in whom decreased activities of daily living, urinary incontinence, and frequent falls are among the major manifestations of this disorder. Pathophysiology. The pathophysiology of delirium is not entirely understood, but it depends on widely distributed neurological dysfunction. Delirium is the final common pathway of many pathophysiological disturbances that reduce or alter cerebral oxidative metabolism. These metabolic changes result in diffuse impairment in multiple neuronal pathways and systems. Several brain areas involved in attention are particularly disturbed in delirium. Dysfunction of the anterior cingulate cortex is involved in disturbances of the management of attention. Reichs et al. 2005. Other areas include the bilateral or right prefrontal cortex in attentional maintenance and executive control, the temporoparietal junction region in disengaging and shifting attention, the thalamus in engaging attention, and the upper brainstem structures in moving the focus of attention. The thalamic nuclei are uniquely positioned to screen incoming sensory information, and small lesions in the thalamus may cause delirium. In addition, there is evidence that the right hemisphere is dominant for attention. Cortical blood flow studies suggest that right hemisphere cortical areas and their limbic connections are the attentional gate for sensory input through feedback to the reticular nucleus of the thalamus. Another explanation for delirium is alterations in neurotransmitters, particularly a cholinergic dopaminergic imbalance. There is extensive evidence for a cholinergic deficit in delirium, Alsay et al. 2013. Anticholinergic agents can induce the clinical and EEG changes of delirium, which are reversible with the administration of cholinergic medications such as physostigmine. The beneficial effects of donepezil, rivastigmine, and galantamine, acetylcholinesterase inhibitor medications used for Alzheimer's disease, may be partly due to an activating or attention-enhancing role. Moreover, cholinergic neurons project from the pons and the basal forebrain to the cortex and make cortical neurons more responsive to other inputs. A decrease in acetylcholine results in decreased perfusion in the frontal cortex. Hypoglycemia, hypoxia, and other metabolic changes may differentially affect acetylcholine-mediated functions. Other neurotransmitters may be involved in delirium, including dopamine, serotonin, norepinephrine, gamma-aminobutyric acid, GABA, glutamine, opiates, and histamine. Dopamine has an inhibitory effect on the release of acetylcholine, thereby contributing to the delirium-producing effects of L-DOPA and other antiparkinsonism medications, Martins and Fernandez, 2012, Trzepich and van der Mast, 2002. Opiates may induce the effects by increasing dopamine and glutamate activity. Polymorphisms in genes coding for a dopamine transporter and 2 dopamine receptors have been associated with the development of delirium, Van Munster et al., 2010. Inflammatory cytokines such as interleukins, interferon, and tumor necrosis factor alpha, TNF-alpha, may contribute to delirium by altering blood-brain barrier permeability, by affecting neurotransmission, Cole, 2004, Fong et al., 2009, Inoue, 2006, Martins and Fernandez, 2012, and even by altering gut immune function, McCoy et al., 2018. The combination of inflammatory mediators and dysregulation of the limbic hypothalamic pituitary axis may lead to exacerbation or prolongation of delirium, Mac-Lulich et al., 2008, Martins and Fernandez, 2012. Finally, secretion of melatonin, a hormone integral to circadian rhythm in the sleep-wake cycle, may be abnormal in delirious patients compared to those without delirium, Fitzgerald et al., 2013. Diagnosis. Diagnosis is a 2-step process. The first step is the recognition of delirium, which requires a thorough history, a bedside mental status examination focusing on attention, and a review of established diagnostic scales or criteria for delirium. The second step is to identify the cause from a large number of potential diagnoses. Because the clinical manifestations offer few clues to the cause, crucial to the differential diagnosis are the general history, physical examination, and laboratory assessments. The general history assesses several elements. An abrupt decline in mentation, particularly in the hospital, should be presumed to be delirium. Although patients may state that they cannot think straight or concentrate, family members or other good historians should also be available to describe the patient's behavior and medical history. The observer may have noted early symptoms of delirium such as inability to perform at a usual level, decreased awareness of complex details, insomnia, and frightening or vivid dreams. It is crucial to obtain accurate information about systemic illnesses, drug use, recent trauma, occupational and environmental exposures, malnutrition, allergies, and any preceding symptoms leading to delirium. Furthermore, the clinician should thoroughly review the patient's medication list. Predisposing and precipitating factors. The greater the number of predisposing factors, the milder in severity the precipitating factors need be in order to result in delirium. Anderson, 2005, Box 4.3. 4 factors independently predispose to delirium: vision impairments, less than 20/70ths binocular, severity of illness, cognitive impairment, and dehydration, high ratio of blood urea to creatinine. Inoue, 2006. Among these, cognitive impairment or dementia is worth emphasizing. Elderly patients with dementia are 2 to 5 times more likely to develop delirium than those without dementia, with increased admission to institutions and mortality. Fong et al. 2015. Inoue et al. 2014. Patients with dementia may develop delirium after minor medication changes or other relatively insignificant precipitating factors. Inoue et al. 2014. Moreover, premorbid impairment in executive functions may be independently associated with greater risk of developing delirium. Rudolph et al. 2006. Other important predisposing factors for delirium are advanced age, especially older than 80 years, and the presence of chronic medical illnesses. Johnson, 2001. Many of these elderly patients predisposed to delirium have cerebral atrophy or white matter and basal ganglia ischemic changes on neuroimaging. Additional predisposing factors are the degree of physical impairment, hip and other bone fractures, serum sodium changes, infections and fevers, and the use of multiple drugs, particularly those with narcotic, anticholinergic, or psychoactive properties. The predisposing factors for delirium are additive, each new factor increasing the risk considerably. Moreover, frail elderly patients often have multiple predisposing factors, the most common being functional dependency, multiple medical comorbidities, depression, and polypharmacy. Lorela et al. 2008. In many cases, the cause of delirium is multifactorial, resulting from the interaction between patient-specific predisposing factors and multiple precipitating factors. Inoue and Charpentier, 1996. Inoue et al. 2014. Lorela et al. 2008. 5 specific factors that can independently precipitate delirium are use of physical restraints, malnutrition or weight loss, albumin levels less than 30 grams per liter, use of indwelling bladder catheters, adding more than 3 medications within a 24-hour period, and an iatrogenic medical complication. Inoue and Charpentier, 1996. Other precipitating factors for incident delirium, which is the term used to describe a delirium that newly occurs during the course of a stay in a clinical setting, include electrolyte disturbances, hyponatremia, hypercalcemia, etc. Major organ system disease, occult respiratory failure, occult infection, pain, specific medications such as sedative hypnotics or histamine 2 blockers, sleep disturbances, and alterations in the environment. Novel situations and unfamiliar surroundings contribute to sensory overstimulation in the elderly, and sensory overload may be a factor in producing ICU psychosis. Ultimately, delirium occurs in patients from a synergistic interaction of predisposing factors with precipitating factors. In addition to the risk factors already discussed, heritability of delirium is an area of investigation. The presence of dopamine receptor genes DRD2 and DRD3, and the dopamine transporter gene, SLC6A3, are possible pathophysiological vulnerabilities for delirium. Polymorphisms in SLC6A3 and DRD2 have occurred in association with delirium from alcohol and in elderly delirious patients with hip fractures. Van Munster et al. 2009, 2010. A locus on chromosome 2 spanning multiple genes including 2 for sodium hydrogen exchange pumps and 3 interleukin-related genes correlate with an increased risk for delirium. McCoy et al. 2018. Finally, despite earlier conflicting data, a meta-analysis showed no association between apolipoprotein E, APOE, and delirium. Adamus et al. 2016. Mental status examination. Initial general behavioral observations are an important part of the neurological mental status examination. The most important are observations of attentiveness and arousability. Attention may wander so much that it must constantly be brought back to the subject at hand. General behavior may range from falling asleep during the interview to agitation and combativeness. Slow and loosely connected thinking and speech may be present, with irrelevancies, perseverations, repetitions, and intrusions. Patients may propagate their errors in thinking and perception by elaboration or confabulation. The examiner should evaluate the patient's general appearance and grooming, motor activity and spontaneity, mood and affect, propriety and witticisms, and the presence of any special preoccupations or inaccurate perceptions. Bedside tests of attention can be divided into serial recitation tasks, continuous performance tasks, and alternate response tasks. The digit span test is a serial recitation task in which a series of digits is presented, 1 digit per second, and the patient is asked to repeat the entire sequence immediately after presentation. Perceptual clumping is avoided by the use of random digits and a regular rhythm of presentation. Correct recitation of 7, plus or minus 2, digits is considered normal. The serial reversal test is a form of recitation task in which the patient recites a digit span backwards, the spelling of a word such as world, or the results of counting by ones, threes, or sevens from a predetermined number. Continuous performance tasks include the A-vigilance test, in which the patient must indicate whenever the letter A is heard among random letters presented 1 per second. This can also be done visually by asking the patient to cross out every instance of a particular letter in a magazine or newspaper paragraph. Alternate response tasks are exemplified by the repetition of a 3-step motor sequence, palm side fist, which is also a test of frontal functions. These attentional tests are not overly sensitive or specific, and they can be affected by the patient's educational background, degree of effort, or presence of other cognitive deficits. In sum, the best assessment of attention may be general behavioral observations and an appraisal of how interviewable the patient is and how much he stays on track with the interview. Attentional or arousal deficits may preclude the opportunity to pursue the mental status examination much further, but the examiner should attempt to assess orientation and other areas of cognition. Patients who are off 3 days on the date, 2 days on the day of the week, or 4 hours on the time of day may be significantly disoriented to time. The examiner should inquire whether the patient knows where he or she is, what kind of place it is, and in what circumstances he or she is there. Disturbed recent memory is demonstrated by asking the patient to retain the examiner's name or 3 words for 5 minutes. A language examination should distinguish between the language of confusion and that of a primary aphasia. See Special Problems in Differential Diagnosis, later in this chapter. Attempts at simple constructions such as copying a cube may be unsuccessful. Hallucinations can sometimes be brought out by holding a white piece of paper or an imaginary string between the fingers and asking the patient to describe what he or she sees. Diagnostic scales and criteria. The usual mental status scales and tests may not help in differentiating delirium from dementia and other cognitive disturbances. Specific criteria and scales are available for the diagnosis of delirium. Foremost among these are the Diagnostic and Statistical Manual of Mental Disorders, 5th edition DSM-5, APA, 2013, Criteria for Delirium, see Box 4.2. The Confusion Assessment Method, CAM, is perhaps the most widely used instrument for screening for and diagnosing delirium, Ely et al. 2001, Box 4.4. A brief version of the CAM, the 3-minute diagnostic assessment, 3D CAM, which is aimed at healthcare staff with minimal additional training, shows high sensitivity and specificity for detecting delirium, Marcantonio et al. 2014. The Delirium Rating Scale Revised 98, DRSR 98, a revision of the earlier DRS, is a 16-item scale with 13 severity items and 3 diagnostic items that reliably distinguish delirium from dementia, depression, and schizophrenia, Trzepich et al. 2001. Both the CAM and the DRSR 98 are best supplemented with other cognitive measures, Adamus et al. 2010. The 4AS test, 4AT, is a third brief screening tool for delirium, which has been validated in multiple clinical situations and suggests degree of cognitive impairment and the need for further testing, Bellelli et al. 2014. There are additional scales used for specific situations. The Memorial Delirium Assessment Scale, MDAS, is a 10-item scale designed to quantify the severity of delirium in medically ill patients, Breitbart et al. 1997. Although it may also be useful as a diagnostic tool, it is best used after the initial delirium diagnosis is made, Adamus et al. 2010. The delirium symptom interview is also a valuable instrument but may not distinguish delirium from dementia. The Nealon and Champagne, NEECHAM, Confusion Scale, Nealon et al. 1996, is an easily administered screening tool widely used in the nursing community. It combines behavioral and physiological signs of delirium, Adamus et al. 2010. The Nursing Delirium Symptom Checklist, NEWDESC, is a more recently validated screening tool that assesses inappropriate behavior and communication, disorientation, and hallucinations but may be more sensitive for hyperactive symptoms and may miss hypoactive delirium, Neufeld et al. 2013. The Confusion Assessment Method for ICU, CAM-ICU, and the Intensive Care Delirium Screening Checklist, ICDSC, are 2 validated critical care assessment tools used to easily and relatively quickly screen for delirium in the ICU, Alsay et al. 2013. Although highly specific, neither the CAM-ICU nor the NUDISH have shown high sensitivity for the identification of postoperative delirium. Neufeld et al. 2013. The diagnosis of delirium is facilitated by the use of the CAM, DRSR-98, 4AT, and the other instruments described earlier, along with the history from collateral sources such as family and nursing notes, a mental status examination focusing on attention, and specific tests such as a writing sample. Physical examination. The physical examination should elicit any signs of systemic illness, focal neurological abnormalities, meningismus, increased intracranial pressure, ICP, extracranial cerebrovascular disease, or head trauma. In delirium, less specific findings include an action or postural tremor of high frequency, 8 to 10 Hz, asterixis or brief lapses in tonic posture, especially at the wrist, multifocal myoclonus or shock-like jerks from diverse sites, coriform movements, dysarthria, and gait instability. Patients may manifest agitation or psychomotor retardation, apathy, waxy flexibility, catatonia, or carphalgia, lint picking, behavior. On physical examination, the presence of hyperactivity of the autonomic nervous system may be life-threatening because of possible dehydration, electrolyte disturbances, or tachyarrhythmias. Laboratory tests. Despite false positive and false negative rates on single tracings, Inoue, 2006, EEG changes virtually always accompany delirium when several EEGs are obtained over time. See Chapter 35. Disorganization of the usual cerebral rhythms and generalized slowing are the most common changes, as illustrated in Engel and Romano's classic paper, 1959. The mean EEG frequency or degree of slowing correlates with the degree of delirium. Both hypoactive and hyperactive subtypes of delirium have similar EEG slowing. However, predominant low-voltage fast activity is also present on withdrawal from sedative drugs or alcohol. Additional EEG patterns from intracranial causes of delirium include focal slowing, asymmetric delta activity, and paroxysmal discharges, spikes, sharp waves, and spike wave complexes. Periodic complexes such as triphasic waves and periodic lateralizing epileptiform discharges may help in the differential diagnosis. See Chapter 35. Investigators have considered bispectral EEG monitoring for adjustment of anesthetic depth and prevention of postoperative delirium. Wilds et al. 2019. In sum, EEGs are of value in deciding whether confusional behavior may be due to an intracranial cause, in making the diagnosis of delirium in patients with unclear behavior, in evaluating demented patients who might have a superimposed delirium, in differentiating delirium from schizophrenia and other primary psychiatric states, and in following the course of delirium over time. Other essential laboratory tests include a complete blood cell count, measurements of glucose, electrolytes, blood urea nitrogen, creatinine, transaminase, and ammonia levels, thyroid function tests, arterial blood gas studies, chest radiographs, electrocardiogram, urinalysis, and urine drug screening. Less routine tests, such as antibody tests against Hu or N-methyl-D aspartate receptors, should be considered when routine labs are unrevealing and there is a suspicion for malignancy. Although they are nonspecific, evoked potential studies often show prolonged latencies. Because most cases of delirium are due to medical conditions, lumbar puncture and neuroimaging are needed in only a minority of delirious patients. Inoue, 2006. However, the need for a lumbar puncture deserves special comment. This valuable test, which is often neglected in the evaluation of delirious patients, should be performed as part of the workup when the cause is uncertain, especially in the presence of unexplained fever or meningismus. The lumbar puncture should be preceded by a computed tomographic, CT, or magnetic resonance imaging, MRI, scan of the brain, especially if there are focal neurological findings or suspicions of increased ICP, a space-occupying lesion, or head trauma. The yield of functional imaging is variable, showing global increased metabolism in patients with delirium tremens and global decreased metabolism or focal frontal hypoactivity in many other delirious patients. Differential diagnosis. Common causes of delirium. The following discussion is a selective commentary that illustrates some basic principles and helps to organize the approach to working through the large differential diagnosis. Almost any sufficiently severe medical or surgical illness can cause delirium, and the best advice is to follow all available diagnostic leads. Table 4.1. For further discussion of individual entities, the reader should refer to corresponding chapters in this book. The confusion-inducing effects of these disturbances are additive, and there may be more than one causal factor, the individual contribution of which cannot be elucidated. Nearly half of elderly patients with delirium have more than one cause of their disorder, and clinicians should not stop looking for causes when a single one is found. Of the causes for delirium, the most common among the elderly are metabolic disturbances, infection, stroke, and drugs, particularly anticholinergic and narcotic medications. The most common causes among the young are drug abuse and alcohol withdrawal. Metabolic disturbances. Metabolic disturbances are the most common causes of delirium. See chapters 57 and 82. Fortunately, the examination and routine laboratory tests screen for most acquired metabolic disturbances that might be encountered. Because of the potential for life-threatening or permanent damage, some of these conditions, particularly hypoxia and hypoglycemia, must be considered immediately. Also consider dehydration, fluid and electrolyte disorders, and disturbances of calcium and magnesium. The rapidity of change in an electrolyte level may be as important a factor as its absolute value for the development of delirium. For example, some people tolerate chronic sodium levels of 115 MEq/L or less, but a rapid fall to this level can precipitate delirium, seizures, or even central pontine myelinolysis, particularly if the correction of hyponatremia is too rapid. Hypoxia from low cardiac output, respiratory insufficiency, or other causes is another common source of delirium. A cardiac encephalopathy may ensue from heart failure, increased venous pressure transmitted to the dural venous sinuses and veins, and increased ICP. Kaplan, 2006. Also consider other major organ failures such as liver and kidney failure, including the possibility of unusual causes such as undetected portocaval shunting or acute pancreatitis with the release of lipases. Delirium due to endocrine dysfunction often has prominent affective symptoms such as hyperthyroidism and Cushing syndrome. Delirium occasionally results from toxins, including industrial agents, pollutants, and heavy metals such as arsenic, bismuth, gold, lead, mercury, thallium, and zinc. Other considerations are inborn errors of metabolism such as acute intermittent porphyria. Finally, it is particularly important to consider thiamine deficiency. In alcoholics and others at risk, thiamine must be given immediately to avoid precipitating Wernicke encephalopathy with the administration of glucose. Drugs. Drug intoxication and drug withdrawal are among the most common causes of delirium. Approximately 50% of patients older than 65 years take 5 or more chronic medications daily, and medications contribute to delirium in up to 39% of these patients, Inoue and Charpentier, 1996. Drug effects are additive, and drugs that are especially likely to cause delirium are those with anticholinergic properties, including many over-the-counter cold preparations, antihistamines, antidepressants, and neuroleptics. Patients with anticholinergic intoxication present hot as a hare, blind as a bat, dry as a bone, red as a beet, and mad as a hatter, reflecting fever, dilated pupils, dry mouth, flushing, and delirium. Both serotonin syndrome, due to excess serotonin from selective serotonin reuptake inhibitors, SSRIs, especially in combination with opioids and antiemetics, and neuroleptic malignant syndrome, due to an idiosyncratic and potentially life-threatening reaction to neuroleptics, may present with fever, dysautonomia, muscle rigidity, and mental disturbances manifested mostly as delirium. Oruch et al. 2017. Van Eveke et al. 2016. Other important groups of drugs associated with delirium, especially in the elderly, are sedative hypnotics such as long-acting benzodiazepines, narcotic analgesics and meperidine, and histamine 2 receptor blockers. Anti-Parkinsonism drugs result in confusion with prominent hallucinations and delusions in patients with Parkinson disease who are particularly susceptible. Corticosteroid psychosis may develop in patients taking the equivalent of 40 mg per day or more of prednisone. The behavioral effects of corticosteroids often begin with euphoria and hypomania and proceed to a hyperactive delirium. Any drug administered intrathecally, such as metrazamide, is prone to induce confusional behavior. Drug withdrawal syndromes can be caused by many agents, including barbiturates and other minor tranquilizers, sedative hypnotics, amphetamines, cocaine or crack, and alcohol. Delirium tremens begin 72 to 96 hours after alcohol withdrawal, with profound agitation, tremulousness, diaphoresis, tachycardia, fever, and frightening visual hallucinations. Excited delirium syndrome, also known as agitated delirium, is a drug-related alteration in mental status with combativeness or aggressiveness. Vilke et al. 2012. Similar to delirium tremens, these patients can develop severe psychomotor agitation, anxiety, hallucinations, elevated body temperature, tachycardia, diaphoresis, tolerance to significant pain, violent and bizarre behavior, and superhuman strength. Excited delirium patients are commonly found to have acute drug intoxication or history of drug abuse. Most patients with excited delirium syndrome will survive, although there still is a high fatality rate estimated at 8.3%–16.5%, Gonin et al., 2017. Awareness among medical personnel regarding this syndrome is crucial for intervention and proactive treatment to prevent deaths. Infections. Infections and fevers often produce delirium. The main offenders are urinary tract infections, pneumonia, and septicemia. In a sporadic encephalitis or meningoencephalitis, important causal considerations are herpes simplex virus, Lyme disease, and acquired immunodeficiency syndrome, AIDS. See chapters 77 to 79. Patients with AIDS may be delirious because of the human immunodeficiency virus, HIV, itself or because of an opportunistic infection. Immunocompromised patients are at greater risk of infection, and any suspicion of infection should prompt culture of urine, sputum, blood, and cerebrospinal fluid, CSF. Prion disease can initially resemble delirium, but the former should be considered if there is prominent myoclonus and cerebellar symptoms in the setting of rapidly progressive cognitive decline. Strokes. Delirium can be the nonspecific consequence of any acute stroke, but most post-infarct confusion usually resolves in 24 to 48 hours. See chapters 65 and 66. Sustained delirium can result from specific strokes, including right middle cerebral artery infarcts affecting prefrontal and posterior parietal areas, and posterior cerebral artery infarcts resulting in either bilateral or left-sided occipito-temporal lesions, fusiform gyrus. The latter lesions can lead to agitation, visual field changes, and even Anton syndrome. See chapter 16. Delirium may follow occlusion of the anterior cerebral artery or rupture of an anterior communicating artery aneurysm with involvement of the anterior cingulate gyrus and septal region. Thalamic or posterior parietal cortex strokes may present with severe delirium, even with small lesions. Other cerebrovascular conditions that can produce delirium include high-grade bilateral carotid stenosis, hypertensive encephalopathy, subarachnoid hemorrhage, and central nervous system, CNS, vasculitides such as systemic lupus erythematosus, temporal arteritis, and Behçet syndrome. Migraine can present with delirium, particularly in children. In contrast, the frequency of delirium in transient ischemic attacks, even in vertebrobasilar insufficiency, is low. Transient ischemic attacks should not be considered the cause of delirium unless there are other neurological signs in an appropriate time course. Epilepsy. Abnormal brain electrical activity is associated with delirium in 4 conditions. 1. Ictely, with absent status, complex partial status, tonic status without convulsions, or periodic lateralizing epileptiform discharges. 2. Postictally, after complex partial or generalized tonic-clonic seizures. 3. Interictally manifested as increasing irritability, agitation, and affective symptoms associated with the prodrome of impending seizures. And 4. From the cognitive effects of anticonvulsant medications. Postoperative causes. The cause of delirium in postoperative patients is often multifactorial, Robinson et al., 2009. Winar, 2001. Predisposing factors to postoperative delirium include age older than 70 years, pre-existing CNS disorders such as dementia and Parkinson disease, severe underlying medical conditions, a history of alcohol abuse, impaired functional status, and hypoalbuminemia. Precipitating factors include residual anesthetic and drug effects, especially after premedication with anticholinergic drugs, postoperative hypoxia, perioperative hypotension, electrolyte imbalances, infections, psychological stress, and multiple awakenings with fragmented sleep. There is no clear correlation of delirium with specific anesthetic route. Upon the cessation of general anesthesia, clinicians may observe the emergence of excitation, or an emergence delirium, Silverstein and Daner, 2013. Otherwise, postoperative delirium may start at any time but often becomes evident about the 3rd day and abates by the 7th, although it may last considerably longer. Clinicians may refer to a postoperative delirium that occurs 24 to 72 hours after the completion of a surgical procedure as an interval delirium. A number of surgeries are associated with a high rate of postoperative delirium. Between 30% and 40% of patients experience delirium after open heart or coronary artery bypass surgery. Patients older than 60 years are at special risk for postoperative delirium after cardiac surgery. Additional factors are decreased postoperative cardiac output and length of time on cardiopulmonary bypass machine, with its added risk for microemboli. In addition to an already high rate of delirium following fractures, up to 35.6% after hip fracture, orthopedic surgeries, particularly femoral neck fractures and bilateral knee replacements, further increase the frequency of delirium by approximately 18%. Emergency hip fracture repair is associated with a higher risk of delirium than elective hip surgery, Bruce et al. 2007. Elective non-cardiac thoracic surgery is also associated with a 9%-14% frequency of delirium in the elderly. Cataract surgery is associated with a 7% frequency of delirium, possibly because of sensory deprivation. Patients who have undergone prostate surgery may develop delirium associated with water intoxication as a result of absorption of irrigation water from the bladder. Other neurological causes. Other CNS disturbances predispose to delirium. In general, patients with dementia, Lewy body disease, Parkinson disease, and atrophy or subcortical ischemic changes on neuroimaging are particularly susceptible. Autoimmune or paraneoplastic processes produce limbic and other encephalotides that may initially present with delirium. Autonomic instability, respiratory distress, and focal or generalized neurological symptoms such as seizures are key clinical findings that suggest the need for urgent further workup, including MRI and lumbar puncture, with prompt treatment if clinical suspicion is high. Electroconvulsive therapy often produces a delirium of 1 week or more. Head trauma can result in delirium as a consequence of brain concussion, brain contusion, intracranial hematoma, or subarachnoid hemorrhage, see chapters 66 and 67. Moreover, subdural hematomas can occur in the elderly with little or no history of head injury. Rapidly growing tumors in the supratentorial region are especially likely to cause delirium with increased ICP. Delirium can result from acute demyelinating diseases and other diffuse multifocal lesions and from obstructive forms of hydrocephalus. Patients with transient global amnesia have ongoing disorientation and appear confused but are not otherwise inattentive or manifest other signs of delirium. Transient global amnesia patients have prominent antegrade amnesia, limited retrograde amnesia for the preceding hours, and improve within 24 hours. In Wernicke encephalopathy, delirium accompanies ocular motor paresis, nystagmus, ataxia, and frequently residual amnesia, Korsakoff amnestic syndrome. Miscellaneous causes. Various other disturbances can produce delirium. Bone fractures are associated with delirium in the elderly, and approximately 50% of those admitted with a hip fracture have delirium. Time from admission to operation in these patients is an additional risk factor for development of preoperative delirium, Giuliebo et al. 2009. In orthopedic cases, the possibility of fat emboli requires evaluation of urine, sputum, or CSF for fat. ICU psychosis is associated with sleep deprivation, immobilization, unfamiliarity, fear, frightening sensory overstimulation or sensory deprivation, isolation, transfer from another hospital ward, mechanical ventilation, psychoactive medications, and use of drains, tubes, and catheters, Van Rompuy et al. 2009. Delirium results from blood dyscrasias, including anemia, thrombocytopenia, and disseminated intravascular coagulopathy. Finally, physical factors such as heat stroke, electrocution, and hypothermia may be causal. Special problems in differential diagnosis. Delirium must be distinguished from dementia, Wernicke aphasia, and psychiatric conditions, see chapters 7, 9, 10, and 13. The main differentiating features of dementia are the longer time course and the absence of prominent fluctuating attentional and perceptual deficits. Chronic confusion states lasting 6 months or more are a form of dementia. Patients with delirium that becomes chronic tend to settle into a lethargic state without the prominent fluctuations throughout the day, and they have fewer perceptual problems and less disruption of the day-night cycle. In addition, delirium and dementia often overlap because demented patients have increased susceptibility for developing a superimposed delirium. The prevalence of delirium superimposed on dementia in community and hospital setting ranges from 22% to 89%, Morandi et al. 2012. Demented patients who suddenly get worse should always be evaluated for delirium. Patients with vascular dementia may have an acute onset or sharp decline in cognition similar to delirium. Distinguishing delirium from dementia with Lewy bodies may be particularly difficult. Both delirium and Lewy body dementia may present with prominent fluctuations in attention and alertness, visual spatial deficits, and visual hallucinations. Key distinguishing features that suggest Lewy body dementia include a prior history of autonomic dysfunction, rapid eye movement, REM, behavior disorder, and anosmia, followed by increasing frequency of falls and Parkinsonism, and severe neuroleptic sensitivity, the constellation of which is not typical for delirium. On the other hand, acute onset, auditory hallucinations, and sleep-wake cycle disturbance without REM behavior disorder are consistent with delirium and not typically seen in Lewy body dementia. Further complicating the picture is that delirium may present superimposed on dementia and the aforementioned symptoms may be present concurrently. In such cases, collateral history is crucial to establish a timeline of progression, and an accurate differential diagnosis may not be possible until after a diagnostic workup is completed. Morandi et al. 2017. The language examination should distinguish Wernicke aphasia from the language of delirium. Aphasics have prominent paraphasias of all types, including neologisms, and they have relatively preserved response to axial or whole body commands. Their agraphia is also empty of content and is paragraphic compared with the mechanical and other writing disturbances previously described in patients with delirium. Psychiatric conditions that may be mistaken for delirium include schizophrenia, depression, mania, attention deficit disorder, autism, dissociative states, and Ganser syndrome, which is characterized by ludicrous or approximate responses. See chapters 9 and 10. In general, patients with psychiatric conditions lack the fluctuating attentional and related deficits associated with delirium. Schizophrenic patients may have a very disturbed verbal output, but their speech often has an underlying bizarre theme. Schizophrenic hallucinations are more often consistent persecutory voices rather than fleeting visual images, and their delusions are more systematized and have personal reference. Conversely, delirious hallucinations are usually visual, and the delusions are more transitory and fragmented. Mood disorders may also be mistaken for delirium, particularly if there is an acute agitated depression or a predominantly irritable mania. Often patients in a manic episode are inattentive, distractible, and hyperkinetic and look as if they are in a hyperactive delirium. A general rule is that psychiatric behaviors such as psychosis or mania may be due to delirium, called delirious mania, especially if they occur in someone who is 40 years or older without a prior psychiatric history. They should be regarded as delirium until proven otherwise. Table 4.2 outlines the special problems that must be considered in the differential diagnosis of delirium. Prevention and management. As many as 30% to 40% of cases of delirium may be prevented with provision of high-quality care. Inoue et al. 2014. Misdiagnosis of delirium results in inadequate management in up to 80% of patients. Michaud et al. 2007. And approximately half of elderly patients affected by delirium actually develop symptoms after admission to the hospital. Early identification of patients with predisposing risk factors is important, especially in a frail geriatric population. Lorilla et al. 2008. In addition, early intervention by geriatricians and others can reduce the rates of delirium. Deschat et al. 2012. Multifactorial intervention programs can reduce the duration of delirium, length of hospital stay, need for institutionalization, and mortality. Shea et al. 2015. These programs, such as the Hospital Elder Life Program, help focus on managing risk factors through interventions that include reorientation, therapeutic activities, reduced use and dose of psychoactive drugs, early mobilization, promotion of sleep, maintenance of adequate hydration and nutrition, and provision of vision and hearing adaptations. Inoue et al. 2014. They also focus on educational programs for physicians and nurses in the detection and management of delirium. Nurses, in particular, spend more time with patients than physicians do, and they may be in a better position to recognize delirium. There are several steps in the management of delirium. First, attention is aimed at finding the cause and eliminating it, from removing the offending drug to treating the infection to administering high-dose thiamine for Wernicke encephalopathy. Second, the delirium is managed with symptomatic measures involving attention to fluid and electrolyte balance, nutritional status, and early treatment of infections. Third, management focuses on environmental interventions. Reduce unfamiliarity by providing a calendar, a clock, family pictures, and personal objects. Maintain a moderate sensory balance in the patient by avoiding sensory overstimulation or deprivation. Minimize staff changes. Limit ambient noise and the number of visits from strangers, and provide a radio or a television set, a nightlight, and, where necessary, eyeglasses and hearing aids. Other environmental measures include providing soft music and warm baths and allowing the patient to take walks when possible. Physical restraints should be avoided if possible and a sitter used instead. Fourth, proper communication and support are critical with these patients. As much as possible, everything should be explained. Delusions and hallucinations should be neither endorsed nor challenged. Patients should receive emotional support, including frequent family visits. They also benefit from frequent reorientation to place, time, and situation. Finally, it is important to address safety for the patient, family, and caregivers to minimize the risks for suicidality, violence, falls, wandering, or inadvertent self-harm. Irwin et al. 2013. In general, it is best to avoid the use of drugs in confused patients, because they further cloud the picture and may worsen delirium. All the patient's medications should be reviewed, and any unnecessary drugs should be discontinued. When medication is needed, the goal is to make the patient manageable, not to decrease loud or annoying behavior or to sedate them. Inoue, 2006. These patients should receive the lowest possible dose and should not get drugs such as phenobarbital or long-acting benzodiazepines. In particular, use of benzodiazepines can have a paradoxical effect in the elderly, causing agitation and confusion. Medication may be necessary if the patient's behavior is potentially dangerous, interferes with medical care, or causes the patient profound distress. Clinicians most often use haloperidol, starting at 0.25 mg daily, for these symptoms because of its higher dopamine receptor potency, lower anticholinergic effects, and the availability of various routes of use. Bledowski and Trusha, 2012. Haloperidol may be repeated every 30 minutes, orally, PO, or intramuscularly, IM, up to a maximum of 5 mg per day. After the first 24 hours, 50% of the loading dose may be given in divided doses over the next 24 hours. Then the dose should be tapered off over the next few days. Inoue, 2004. There is mixed evidence to support the preventive use of haloperidol prior to the development of delirium, although it may reduce severity and duration postoperatively, as well as duration of hospital stay. Gosh and Nicholas, 2014. Kalizvart et al. 2005. One multi-center study found no benefit of either haloperidol or ziprasidone compared with placebo specifically in the management of hypoactive or hyperactive ICU delirium. Gerard et al. 2018. The atypical antipsychotics, including risperidone, olanzapine, quetiapine, and aripiprazole, may be used at low doses. Addard et al. 2008. However, safety and efficacy of the atypical and typical antipsychotics are similar. Tor et al. 2013. Results in favor of acetylcholinesterase inhibitors for delirium management have not been borne out in controlled trials, although in some cases, such as in patients with Lewy body dementia, they can be helpful. Addard et al. 2008. Martins and Fernandez, 2012. Tabbitt and Howard, 2009. In addition, the existing evidence does not support the use of acetylcholinesterase inhibitors after surgery for prevention of postoperative delirium. Alsay et al. 2013. Addard et al. 2008. Tabbitt and Howard, 2009. Other medications such as valproate, ondansetron, or melatonin may be effective and safe in selected cases. However, melatonin receptor agonists, melatonin, ramelteon, L-tryptophan, have shown inconsistent outcomes for delirium prevention. Choi et al. 2018. Walker et al. 2016. There is growing evidence that the sedatives and hypnotics commonly used in the ICU can produce delirium. Hip and Ely, 2012. Dexmedetomidine, an alpha-2 agonist, has gained popularity in the ICU due to decreased respiratory suppression and evidence from recent trials demonstrating reduced delirium prevalence as compared with opioids and GABAergic drugs such as benzodiazepines. Hip et al. 2012. Pavone et al. 2018. Dexmedetomidine has also been shown to reduce the incidence of postoperative delirium, especially after cardiac surgical procedures. Pavone et al. 2018. Prognosis. The prognosis for recovery from delirium is variable. If the causative factor is rapidly corrected, recovery can be complete, with an average duration of delirium of approximately 8 days, 2 days to 2 weeks. Delirium present at discharge is associated with a 2.6-fold increased risk of death or nursing home placement. McCabe et al. 2006, and delirium persisting after hospital discharge is associated with a 2.9-fold risk of death within the following year. This risk appears to be reversible with the resolution of delirium, Keeley et al. 2009. The link between delirium and subsequent long-term cognitive impairment is also firmly established, Lulich et al. 2009, Morandi et al. 2012. In the elderly, delirium may not be a transient disorder. For them, the duration of delirium is often longer than that of their underlying medical problem. Moreover, after hospital discharge, older patients who are delirious may not recover back to baseline, Inoue et al. 2014. In one study, 14.8% still met criteria for delirium 12 months after discharge, sometimes referred to as a persistent delirium, McCusker et al. 2004, Morandi et al. 2012. A partial non-progressive delirium with some but not all criteria for delirium may persist in many elderly patients, sometimes referred to as a subsyndromal delirium, Martins and Fernandez, 2012. Delirium is an independent predictor of adverse outcomes in older hospitalized patients, particularly in the presence of baseline cognitive impairment or dementia. It is associated with an increased mortality rate and may accelerate cognitive decline, Adamus et al. 2006, Inoue et al. 2014, Lulich et al. 2009, McCusker et al. 2002. Delirium in the elderly predicts sustained poor cognitive and functional status and increased likelihood of nursing home placement after a medical admission. Hypoactive delirious patients appear to be at particular risk because of complications from aspiration and inadequate oral nutrition as well as falls and pressure sores. In general, however, clinicians can greatly improve prognosis with increased awareness of delirium, more rapid diagnosis of the causative factors, and better overall management.